Hi, everyone, and welcome to ABCs of Anesthesia. Another special episode where I've got Dr. Lee here. He's about to he's about to sit his GPA, so GP anesthetic exams, which is pretty full-on experience. Like you've got less than a year to study for this, and you learn so much in that time. And so, Lee, you've done a lot of homework for this, which is I've pretty much asked you to go away with and make some stems yourself. So you've self-directed, made some stems with patients with particular things in their history, such as hypertension or COPD, just lots of general, very common things that any anesthetist would need to know. And the aim was to drill a very specific part of the exam, which is what would you want to know on your perioperative assessment, or, a question like that. And often this is done in a history exam investigation framework. But also we've gone through a few other tips as well, such as when you present these things, history examination investigation is the way we gather information. So these are our information gathering tools, talking through history, examination through all the mechanisms we have with that, and then specific investigations. But when we synthesize the data that we get from history examination investigation, we find that the most useful way of presenting this is, what is the disease? Like, what is the severity of it? Obviously, that's really important. And how stable is it? Are there any acute exacerbations? Also, if you look at a disease, those are probably the most important things about the disease itself, and have lots of signs and symptoms and variables that we draw on from history examination investigations. But we want to know what the cause is, because the cause could have a whole other problem, disease states, problems for the anesthesia. And then we also look at complications. This disease can cause many complications, and those complications are relevant as well. So if we use that framework, we get a really comprehensive answer, and it's structured, and the examiners will know what you're talking about and be able to follow you if there's a lot of words. So now the full disclosure is I am an examiner for the DRGA, or the RGA as it's called now. But all of this stuff is just general information. I'm giving none of this is necessarily on the exam, though parts, any exam will have certain elements of this, and that's no secret to anyone. So for full disclosure, this is not me putting anything that's on the exam and feeding it to you, but mainly for learning for everyone, really. So let's get started. So the first stem that you had was a 61-year-old male for TURP, so transurethral resection of prostate, secondary to LUT, so the lower urinary tract symptoms, with a history of hypertension, taking perindopril, amlodipine, and tamsulosin. So let's say that's the stem, and the question is, what would you like to do in your, what would you like to know in your pre-anesthetic assessment? Go for it.
So in relation to my pre-anesthetic assessment, in addition to my routine pre-anesthetic assessment, specifically for this patient, I'd focus on his lower urinary tract symptoms as well as his hypertension. Again, looking at, so specifically with his hypertension, I noticed that he's on 2 antihypertensives. Are they combined? So initially, are they a combined medicine, or are these individual medicines? Because there will need to be a dose alteration and management situation in the perioperative phase. So continuing his calcium channel blocker, but also withholding his perindopril.
Great. And just to clarify, so you said dose alteration. So would you cease all ACE inhibitors in patients, or?
So again, from the reading and suggestion that I have available, ACE inhibitors the day of surgery, but continuing all other medications is ACE inhibitors and A2R blockers are recommended to be withheld on the day of, or 24 hours prior to surgery. And all other blood pressure medications should be continued if there's indication of such.
And so, Lee, they might be an updated guideline, but essentially I'm happy for everyone to take everything beforehand. But I accept that maybe you've read something new, and there's plenty of people that would stop it, especially if it's an operation that had some level of maybe risk of hypotension and blood loss, or maybe, they're worried about something like that. So that's fair.
I think that's fair as well, Justine. So I was just looking through most recently to try and come up with these steps.
That's right. What's specific? What's important about your answer now is I want you to mention the words severity, stability, cause, complications, because I know exactly what you're talking about. And if you're, I think from the last chat we had, you know that there's a tendency for you to have lots of words. We're going to try and minimize those words because the exam, each component, this component will be 3 minutes, 4 minutes max. And we're going to hone you down to just like, this is exactly what you want to say.
Yeah.
So every time you don't say those words, just as a drill, I'm going to go, hey, severity.
That's right. So so specifically for this patient and his hypertension, I want to know initially the cause. Is his primary or secondary hypertension? And we'll explore those later if required. We got his severity. I notice he's on 2 antihypertensives. We need to know how stable is he on those antihypertensives.
What do you mean severity?
So severity for this patient is his baseline readings of his blood pressure. And again, this is not just in the room in the preoperative assessment phase. This is probably going to look back over a course of the last 6 months, if that's the case, if there's other investigations available. So covering ambulatory blood pressure monitoring, his diagnostic criteria, and why he was increased or dosed.
Hypertension is such a straightforward thing that I'm happy that you said I'll take lots of measurements, see what the level is, and if it's malignant.
Yes. So stability, again, seeing how stable he is, whether or not there's been recent dose alterations or changes or changing kidney function. Noticing that he does have a risk of post-renal kidney again, so it's just noticing that he has an indication. So lower urinary tract symptoms can lead to a post-renal cause for a kidney injury. So that needs to be investigated, whether or not this is acute or short, long-term. So whether or not he has any other end organ effects, we're looking at chest pain, atrial fibrillation, other implications of hypertension. Is this isolated hypertension only? And then the complication. Sorry, yeah.
Yeah, I think when you talk about end organ dysfunction, you're talking about complications. So let's put it all into what are the complications. So tell me again, what are the complications you might observe in someone with hypertension?
So hypertension is a vascular disease. So we've got evidence of stroke, ischemic heart disease, the elements of chest pain, reduced exercise tolerance. We could have other comorbid conditions, atrial fibrillation or heart failure. There might be an element of COPD or lung disease, which may complicate.
That's too far. I think once you start saying atrial fibrillation, COPD, I'd almost just keep it at, I'm looking for any end organ dysfunctional complications of hypertension, like headaches, visual disturbances, chest pain, and maybe some renal complications. And that's all you need. You've given a pretty, probably more than what's needed for an answer for hypertension, but that's easy to learn more and come down to it. I'll just give you an example of what I might say just for the recording. I'd be concerned about this patient's hypertension. I'd want to know the severity. I'd want to know a recording of what the blood pressures have been lately and the treatment and compliance on treatment. And want to know how stable it was, whether it was all over the place, or if they're getting many blood pressures above 180. I think about the cause. Mostly this is essential hypertension, but if there's a secondary cause like a pheochromocytoma or hypothyroidism, want to be alerted to that as well. But it doesn't look like it from the history. And I'd want to know any complications. If this is malignant hypertension, headaches, chest pain, any signs of end organ dysfunction, which is pretty rare. But if there were these signs, then I'd be concerned about that too. That's probably as brief as I would make it, because I don't think I need to go on too much about hypertension. Keep going. What else do you want to know on your pre-anesthetic assessment, aside from your usual things?
Specifically for this patient with respect, and his lower urinary tract symptoms, given that's my sort of things, we need to know surgical position. So that's a discussion with the surgeon.
This is going to be just assessment. So you're to talk about surgical position. What kind of anesthetic are you going to do for this?
So again, this is an option for discussion with patient understanding. There are options for his general anesthetic, we've got a general anesthetic and we've got regional neuraxial anesthetic options. So therefore his suitability, so other things in my anesthetic assessment, usual and routine anesthetic assessment for this patient would include.
I'll stop you there. I'll stop you there. So you've mentioned spinal anesthetic. What do you want to do on assessment to check that they're okay for a spinal anesthetic?
So on assessment for his spinal anesthetic, so we need to look at the palpable spinal, look at the back and visualize the region that you're going to use. So palpable spinal anatomy, previous operation surgical scars sites. We've got infection or overlying erythema that might indicate an underlying concern or increase our risk of infection, and his bleeding risk.
Yeah, good. So pretty much I'm worried about whether this spinal is going to be easy to do and if there's any, absolute contraindications. So yeah, that's right. So I'm thinking anatomical problems, sepsis or local infection, or anything that will cause a bleeding risk, coagulopathies, anticoagulants. And I'm thinking of cardiovascular instability. So let's say severe stenosis, or they had something else that might be or cause a massive drop in blood pressure because of it. Okay, that's good. Hey, so takeaways from that. I like that you said, in addition to my usual anesthetic assessment, because this question might be about that, but chances are it's about, well, what we're going to go through is always, how do you give a really good assessment of certain pathologies? So that was great. You had a good structure. I want you to, like we mentioned, label cause, severity, stability, cause, complications. And then if this one had something about like, this could be a neuraxial technique, go straight into assessment for suitability for the neuraxial technique. That's about it for that, really. Shall we go to the next one?
I appreciate that. Yeah, no, let's go. Yeah.
Right. And there's now a lot of this exam could be a bit of a game, using the right words to give your examiner confidence. And one particular tick I've noticed is that you say again and again. And I'd say if you can be mindful, it's not the biggest deal, but if you can be mindful that the examiner won't ask you something if you've already said it. So to say again might make them feel a certain way, like, oh, well, you haven't said it. Why are you telling me you said it again? Because they're asking you, right?
Habits and communication and situations across the table on a Zoom situation.
Everyone
has
a thing that where they say something.
Yeah.
The next question is: a 70-year-old male presents for pre-anesthetic assessment for elective excision of melanoma and possible flap. He has a history of angina and PCI with single drug-eluting stent 18 months ago. So what do you want to know on assessment?
So on my preoperative assessment for this patient, so guys, in addition to my routine perioperative assessment for this patient, there's the two things that I want to know for him is the implications of his ischemic heart disease, his angina, PCI. There's, as well as his suitability for a regional component for his operation.
And what do you mean regional?
Nerve blocks, or so is this the location of the lesion? It's a forearm lesion. Is the flap being taken from a different set? Is the different things? So it all depends.
What I just add to that, suitability of regional and or sedation, because often these are just, even the flaps are done with local and sedation, especially with the elderly patients with lots of comorbidities. Great. So keep going.
Yeah. So specifically with respect to his ischemic heart disease and interpretation of ischemic heart disease with his angina as PCI, drug-eluting stent, I want to know the severity of it, his symptoms and impact on his daily life. We need to assess the stability, and so
as soon as you say severity, I need data points. You can't say severity and move on.
Yeah. Okay. So I'm trying to just sort of scaffold my answer and then come back and review. But okay. So severity points for this, we have: is his angina stable, unstable, or is it persistent, present at rest with activity, and at what level of activity? His activity of daily life and how it affects that, and what that equivalates to MET scoring, and so metabolic equivalence for his anesthetic risk benefit adaptation. We have ongoing chest pain, shortness of breath, any subsequent sequelae of his ischemic heart disease, is there any elements of with complications, so heart failure, associated with pitting edema, shortness of breath, raised JVP? Is there ongoing chest pain? Is there
No, that's good.
Yeah.
Where are you at in your framework? What have you taught?
So I haven't gone through course, but I think I've covered. From my point, I've covered severity and stability and possible complications of those which may impact on my decision further on. So the cause again would be exploration of those high risk factors. He's male, he's elderly, does he smoke? Is there any other underlying cardiac conditions associated with this that may have triggered his ischemic heart disease? Mm-hmm. His diet, and again, assessing his SNAP function prior to those things. Other things specifically with the drug-eluting stent, is he on dual antiplatelets? Is he receiving cardiology follow-up and discussion for those? They're things that will indicate whether or not this is we have suitability at this stage.
Any other things that would help you determine severity?
So he's echo, echocardiogram. We've got, just trying to piece this back together in my head.
That's good. It's investigations. So any other?
So examination, investigations, and functional testing.
Oh, sorry, you're absolutely right with echo. Any other specific kinds of echo?
Yeah, so stress echo, if this patient's unable to perform an exercise stress test or otherwise.
Hey, that was great.
And stress echo as well.
That was really good. And so again, like with the way we do that, if you mention all the words, you'll never fall flat because you know a lot of the data points here. I'll just give my answer to that as well. Oh, by the way, in that framework we had, this would include thorough chart review. So yeah, definitely adding that to. In addition to my routine anesthetic assessment, I'd review all the notes from specialists and chart review, but I'd really want to focus on ischemic heart disease and the suitability for local sedation, which is often what happens in these cases. So specifically about the ischemic heart disease, I want to know severity. How bad was the heart attack? How long ago? What was the management? Are they on maximal medical management? Do they have chest pain? Is it ongoing? And how stable is it? Have they had any recent exacerbations? Is it stable? Is it relieved by any particular medications like GTN? And that would tell me my severity as well as echo, stress echo, angio, any other investigations that would allow me to have some level of heart function, and that would lead on to exercise tolerance as well. In terms of the cause, I want to know if there's any modifiable risk factors. Is patient smoking? Is it diabetes under control if they have it? Is it hypertension under control? Other non-modifiable things like male past history, I don't necessarily care to mention. Complications, I'm worried about end organ function. This is essentially things like heart failure. So heart failure, I'm looking for signs of edema, raised JVP, crackles in the lungs, or any previous history of APO, and whether there's other rhythm disturbances like atrial fibrillation, which is pretty common. Note that in that I said complications like heart failure and then the symptoms, instead of heart failure and JVP. It's a subtle thing, but it just means that it sounds organized. Yeah. Great. No, that's good. Any questions? These are great scenarios you come up with, by the way. They're just really stock standard stuff.
I think this was the challenging part, trying to create that scenario for what could I do and what would be appropriate for a scenario in a situation of, is this suitable to be? And I think towards the end of the stems, I thought it's one of those things that could create a discussion of this patient is not suitable for scenario. But I think that's fine. So just me trying to stretch myself a little bit to create a scenario.
So for my final exam, it was 12 months of study. It's pretty grueling, but we were just constructing scenarios, and it helped because on the day we actually predicted 2 to 3 questions from the short answer as well as the Viva that were never asked before. Like just from thinking about stuff and looking at the latest articles, we'd come up with these questions. So the exam was so much easier because of it. So this will go a long way, I think. Okay, next question. 64-year-old female for one of the LETS procedures. And importantly, they've got a 50-pack year smoking history. So LETS procedures like having a hysteroscopy essentially with a bit of an excision. What would you want to know on assessment?
Okay, so in addition to my routine perioperative assessment and peri-anesthetic assessment, I'd perform a thorough chart assessment and review all available notes. I'd assess the total history from the patient, specifically focusing on her smoking and the significant end organ effects. Not significant end organ. The significant effects of her smoking and her respiratory function. And again, suitability for sort of spinal as well. But that's sort of later at this stage is a rather rapid procedure. I think doing sort of long-acting neuroaxial technique would be would contraindicate. So specifically for her smoking, and the suggestion is, my concern here.
I'm just going to stop you there.
Yeah,
and there's a common thing, right? Like I don't want you to start getting tied up with words, because as soon as you started talking about the neuroaxial, I was like, oh look, we're getting off track here, and you're saying words that probably are making the examiner go, why are you saying that? So don't shoot yourself in the foot. I want you to, let's go say the words severity, stability, cause complications.
Yeah. So specifically with respect to smoking and possible COPD, there's a cause of a COPD. We need to notice so smoking underlying possible alpha-1 antitrypsin deficiency. We've got severity, how antibiotics, admissions, exacerbations, recent steroids. We need to say stability. We need to know other things, so to cough, sputum production, and so things that are going to impact on our anesthetic, possible increased, so pulmonary hypertension as a possible subset. We've got stability, how long has she been unwell, has she noticed any of these other complications, and has there been a deterioration in her overall functioning? Is she short of breath at rest? Is she short of breath with mild exercise? Or is she able to perform formats, so climbing a set of stairs, doing a 6-minute walk test? There's complications for COPD, increased chest pressures, air trapping and breath stacking, and infections, increased mucus-like secretions, which will lead to complications with airway techniques.
So let's say we're assuming they've got COPD. What complications are we thinking of?
Hypoxia, hypocarbia, and recovery stage. They could be bullous emphysema. They might need to chest X-ray, auscultate the chest. And so there's increased pressures. We want to avoid pneumometastamal, pneumothorax as part of overpressures.
Okay, good. So the one other complication that you might say, I wouldn't go again too deep, like COPD, bullous lung disease. I'd be worried about high pressure in ventilation, sure.
Yeah.
But I want you to think of lots of exacerbations means that you're going to have the usual ventilatory problems, but then right heart dysfunction if they've got pulmonary hypertension. That's the other one. So I'll just give you my assessment. So 60-year-old female for let's proceed 50 pack year smoking history. So in addition to my routine anesthetic assessment, I'd review all the notes with their smoking. I just want to know how many pack years and whether they're trying to quit as well, because that's a big part of trying the perioperative journey. Let's assume they've got some risk of COPD. So this is where the complication of smoking becomes its own set of histories, which you did correctly. So you went COPD. I want to know severity. I want to know if they've got lung functions tests, what level of it is moderate or severe, based on the FEV1 and FVCs and the ratio. I'd want to know if they're on treatment and if they're compliant with that, and any recent exacerbations. That tells me severity and stability, as well as their METs and their exercise tolerance as well. I'd want to know the risk factors we already know. That's smoking, and complications. I'd want to know if there's any, if there's any complications from repeated exacerbations, if there's any bullous lung disease, so I'd have to change my ventilatory parameters or be cautious with high pressure ventilation. I'd want to know about if any right heart dysfunction or coronary artery disease based on the fact that they've got smoking history, as well as hypoxemia causing pulmonary hypertension.
Yeah.
And finally, a suitability for a neuraxial technique if all of these markers were quite severe. When you mentioned alpha-1 antitrypsin deficiency, I think you mentioned together with smoking.
Yeah,
but I feel like
the things, because
like one causes COPD, not both really.
Yeah.
That would be a thing.
Yeah.
And then they're not going to give you something so random
No.
in the GP exam, I think.
Yeah, I just have to sort of try and stop, sort of find things and fit those into their things, and use and again, you sort of hear it sort of mentioned an Occam's razor, and just trying to cut out my overthinking type of response.
Absolutely. Okay,
just trying to keep it.
We've got an 82-year-old female with a distal radius fracture, post a fall on an outstretched hand in the car park of a local shopping centre. The orthopedics team are visiting Snaresville next week and would like to perform an ORIF, or let's say they're visiting soon so that you can perform this ORIF, and her GP health summary includes medications, irbesartan, metoprolol, furosemide, as well as salbutamol and tiotropium. Good. So in this one, you've got to kind of assume some diseases because of the medications. I suspect that that's the next level of things, but let's go with this. What do you want to know in your assessment?
So in addition to my routine perioperative assessment and thorough chart review for this patient, chasing notes and available options, noting current medications with suggesting of hypertension, rate control, and a diuretic. There's suggestion of heart failure, congestive cardiac failure, which may be indicated as well with the wheeze and subsequent treatment with salbutamol and tiotropium.
I'd say then
extrapolation of things.
I'd then say, are you treating heart failure wheeze with Ventolin? Like, is that a thing?
No. So again, this noted. I don't. But we sort of see this. I'm seeing this a little bit more where we're seeing treatment of wheeze and extrapolation rather than investigation of wheeze is just dramatically
with
GP.
Hey Lisa, this is going to be completely losing track of what we need, which is we're keeping it so simple. The exam is going to be so much simpler than us talking about the random treatments for random things in random places. In fact, I want you now just to go straight away through CCF.
Yeah. All right. So let's assume. So looking at the medications, we've got. We've got A2R. So A2R blocker. We've got.
I'm going to stop you there, Lee. I want you to tell me assessment of CCF.
Yeah. I'm just trying to bring myself back in and sort of come back to it. This is what I'm sort of trying to do, and what happens often in my sort of exam if I struggle, and it's trying to bring myself back. So specifically for this and suggestion of congestive cardiac failure in this 82-year-old female, we're looking at cause. So is this cardiac related heart failure? Is there underlying heart disease, structural heart disease, ischemic heart disease, pulmonary COPD, which might lead to then our right heart strain and failure on that side. Then, so again, severity for this, activities of daily living, fatigue at rest, exercise, so shortness of breath on exertion, shortness of breath at rest. I just got myself trying to chase all these minor things. So, of course, we've got structural heart disease or lung disease, which putting pressure. We've got in severity.
It's good.
And then, and stability, severity. Is there any acute exacerbations? Recent increased dose of furosemide? Any presentations to hospital? Do we have admissions, ICU presentations? We've got reduced functioning, increasing shortness of breath, more reliance on puffers, and with the interpretation of her wheeze. We've got reduced exercise tolerance, worsening swelling or weight gain. That might be suggestive. Stability, how she's going, regular medication attendance, routine follow-up, chasing those cardiac.
Stability is exacerbations of the disease.
So, okay, recent exacerbations.
Mhm.
Which I mentioned previously.
Yep.
So instead of severity, so exacerbations, increased fluid, increased weight gain recently, changes or compliance or adherence to fluid restriction. And then complications are blood pressure management. We've got heart.
Tell me what the complications are of CCF.
So complications of CCF, heart strain, increased risk of cardiac events. We've got shortness of breath.
This is kind of a hard one if you haven't thought about
it. It is.
So
complication.
No, that's right. So, I mean, this is all part of learning. This CCF, I often find that these patients have atrial fibrillation, say it's a dilated heart, or because they're on all these medications to decrease fluid, they have some level of renal impairment as well. Those are probably the big things I'm seeing. With heart failure, and if they've got complications like APO as well, that's a problem. So I'd keep it simple and go, I'm looking for complications of CCF. This could include things like APO or congestion in the lungs, atrial fibrillation, or some renal impairment. Just mention those three things and just move on. Like, don't apologize for not having an exhaustive list, because there could be lots of things. In terms of causes, it's fair to say, it's fairly safe to say that most of the time people have heart failure is due to ischemic heart disease. They have a knocked out part of their ventricle, regional wall motion abnormalities, and now their heart doesn't function. So that's one of the common things. But there's actually lots of causes of it. There's ischemia, there's anemia, there's drugs, there's thyrotoxicosis. There's all of these different causes of heart failure, but you just have to name a couple of them and move on. This is not a physician exam. If it was a physician exam, none of us would be able to pass. But that's why we have physicians there helping us through these, and that's why we're in Anaesthetics. I'll just tell you how I'd mention it just for the recording. So in addition to my routine anesthetic assessment, I'd review all notes, and looking from this history, this patient probably has an element of heart failure, as well as maybe some asthma, COPD. Because we've already done the COPD part, let's just focus on the CCF. I really care about the severity and stability of disease. Have they had many exacerbations, hospitalizations, and then what's their current function, exercise tolerance? I'm worried about symptoms such as shortness of breath on exertion, orthopnea, paroxysmal nocturnal dyspnea, pitting edema, swelling, inability to lie flat. And then I'd look at all investigations for that as well. So don't forget to say, I'd look at examination with the JVP and looking for crackles in the lungs. I'd also look for any stress echoes or echo findings, as well as any CPX testing. The echoes will tell me a lot about the heart function and what level of type of failure it is, if it's diastolic dysfunction or systolic dysfunction. You don't have to mention that detail. Causes, we mentioned lots of different causes. Mainly this is myocardial ischemia. It could be other things such as anemia or drugs or thyrotoxicosis, but most likely this is going to be ischemic. Complications, a few things I'm concerned about is if they've had APO or congestion in the lungs, some element of pulmonary hypertension, if they've had AF or some renal impairment as well. Done. That's my... and at each step, I hope it's clear that I'm just going severity. I think you can often put severity and stability together, because then you go, I'm worried about the severity and stability of disease, any acute exacerbations, hospitalizations, that's my stability. And then severity is all the other stuff, and include the investigations in that. Let's just do one more. A 43-year-old female for a lap collie with a background of obesity and type 2 diabetes. This is a good one. What would you like to know, Lee, on assessment?
So, in addition to my routine perioperative pre-anesthetic assessment, specifically for this person, so exploring her obesity and diabetes. So obesity, specifically looking at cause. Does she have an underlying metabolic syndrome on top of her diabetes as well? Is this sort of a SNAP-related lifestyle modification, obesity with reduced exercise diet? Is there some smoking? Is there a genetic component? Endocrine as well, looking at the hypothyroid suggestions. So diabetes, looking at, so the cause is related to her obesity, directly related to obesity, genetic predisposition, and say lifestyle factors, smoking, nutrition, exercise, alcohol consumption. Is there, so again, severity of her condition is looking at her medication list, trying to extrapolate what medication she's on, number of medications, hospitalizations, and
I'm gonna get you to.
I'm just trying.
I'm gonna go straight to what are the complications of obesity that you are most worried about for anesthesia?
So specifically for airway, so complications of obesity and suggestion for anesthetics. So anticipated difficult airway, difficult bag mask ventilation, and possible difficult intubation. We have a increased risk of sleep apnea and
Good. Hey, I'm going to stop you there. So I would keep the obesity one kind of brief, but there's little things that you can change, and most of the things aren't relevant. So, the cause of obesity, I like that you said maybe there's some genetic cause. Maybe, there's some other aspect here that I'm not concerned about or worried about. So that's okay to mention that. In terms of severity, that's just what is the absolute weight of this patient? What's the BMI? These things matter to me, because I've only got obesity up there. In terms of stability, kind of irrelevant, really. Complications, though, definitely. Have they got diabetes? Have they got airway stuff like you mentioned, airway issues, signs of difficult bag mask or intubation? And do they have OSA or obesity hyperventilation syndrome? And the other thing that might come up is, have they had an operation such as a lap band? Because that means that they're at aspiration risk. And if they're on Ozempic as well. So that's my obesity thing. It's not too detailed. I wouldn't go on too much about it, but the absolute weight and the complications matter most. And don't worry, this is part of learning the structure. Like, I'm giving you a structure and knowing that sometimes it really matters that I know, like heart failure, the cause really matters. Whereas in this one, the cause is less important. People eat a lot. It's Australia. Tell me about your assessment of diabetes.
So again, cause is this most likely underlying related to obesity. Specifically, so severity, we need to know the current HbA1c, her baseline blood sugar levels, and her medication regime. We need to know medication regime for that sort of risk, as Ozempic being aspiration risk, and so we need to know those things. We also need to know medication rationalization in perioperative phase. We also need to, and again, is she suitable for scenario at this situation? Raised BMI, difficult blood sugars might not be suitable.
I'm going to get you to always focus on the framework. Tell me cause, severity, stability, or complications. Don't deviate from that.
Don't deviate. Okay, so severity, we've got, again, so current HbA1c and any recent hospitalizations, HHS or HONC syndromes. We've got hypoglycemic episodes and hyperglycemic episodes, which may also play into that as her blood pressure control. Has she had any stability, medication dose, again, I've gone over that as well. So hospitalizations, HONC, HHS, we've got hypo and hyperglycemic episodes, and then complications. Looking at microvascular and macrovascular disease associated with her diabetes.
That's great. You covered everything I wanted you to cover in that. So I'll just give my spiel on it. So for diabetes, I really want to know how the patient's severity and stability is. So how long have they had diabetes for? Is it type 2, is it type 1? And is it, what are the blood sugar levels? How stable are they? Have they had many hypos? What's the HbA1c? I want to know we've kind of gone through the cause. I want to know the complications. So have they had hypo episodes or any kind of DKA or HONC type syndromes, as well as the macrovascular complications? These are retinopathy, renal dysfunction, as well as strokes, heart attacks. This is now the one where the medications really matter. So the full framework, I've told you severity, stability, cause, complications, but the extra high level of this is now treatment and treatment complications. And this is where it really matters. Same with obesity. Treatment was a gastric band. The complication of gastric band is aspiration risk. So in this one, it really matters because we know that we want appropriate cessation or modification of insulin and oral hypoglycemics. Flozins really matter because we got to cease them 3 days before so they don't get euglycemic ketoacidosis. And if they're on a Ozempic type drug, we're worried about aspiration risk. So this is now the advanced level of the framework, which is when the treatment matters and the treatment complication matters. That's a good session, Lee. So, if you were to take home just one thing from our session, what would that be?
To take away one thing from our session is that the framework and the scaffolding, I think, is key to being able to get my point across.
What are you going to do? Action, because everything's about specific actions. What are you going to do in this exam?
So, what am I going to do with this exam? So,
to stick to the framework.
Stick to the framework. Stick to this.
But how? How are you going to make sure?
How am I going to practice?
No, I'm going to give you. You're right. It is practice.
So
I want you to say. I wonder if you're allowed to write on your hand severity, stability, cause, complications, and so you have to say those words. Like you have it in yourself that if I'm not giving those words and then just following one sentence after each word, that's where my risk is.
So taking in those, really committing those 4 words to memory and what they actually mean, was broken down as well. So that stability component being the acute exacerbations plus or minus any changes there, hospitalizations. So and that and then the severity is the history, the exam and the investigations component played into that. So that's taking in just my wording, my trying to avoid over talking and filling space whilst my brain catches up, and I think is a challenge. And I think that's, for me, that's where that practice comes in. And I think just going, okay, I need to go this, and bring that back to where can I be without overcomplicating it and keeping it as simple and as task and directed as possible, I think is where I can make my most improvements for that time.
This is a great takeaway. So for this particular section, it'll absolutely come up in the exam. You're going to say, in addition to my usual anesthetic assessment, I'd review all the relevant specialist notes and the patient's history. And for diabetes, I want to know severity, stability, cause, complications. For CCF, I want to know severity, stability, cause, complications. You'll go so far. I already know you have the knowledge to pass this exam. That's an absolute given. And the way you're going to absolutely guarantee that is by saying those words. The more you sense yourself going off on a tangent, I want you to just go, all right, I'm going to stop there. I'm just going to restart, take a breath. I'm a bit nervous. It's okay to say you're a bit nervous. Then the examiners go, yeah, we get it. That's fine. There's plenty of times I've said something along the lines of, whoa, I'm actually pretty nervous, because I start rambling as well. So to call it out, I think decreases the power of the nerves a lot. And just do that. I know you have the knowledge to pass, and this exercise was incredibly useful, I think. And I know it'll be very useful for anyone listening and watching.
I think it was good. It was good. It was good to think about it as what could I get, and trying to then extrapolate my current situation to the situation where the exam is going to take place is that sort of challenge to sort of piece it together, and I can sort of understand that sort of challenge on the questions and the writing and the structures components for those people doing the examination.
Good. So we'll call that a day for this particular topic. Thanks everyone for listening and watching, and hopefully it was useful. We'll see you again next time for another session of exam preparation. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.